I'm very pleased to be here today. I always enjoy speaking to this group, and particularly about this topic, which is one of my very favorite topics. I would like to share with you today how important cataract is and what a significant problem it is from the standpoint of function and quality of life. I would also like to impress upon you the great significance and public health implications of this problem, and also share with you some exciting new developments so that you can use some of this information with patient education. I think that's so important, and I think with information and public education you can do a great service to your patients in helping to solve this great public health problem. The normal lens of the eye is a clear structure that's located behind the pupil. This is the human eye in front section, and we might want to dim the light so they can see this a little bit better, and just leave on the note lights, and please try to stay awake. At least think about what you're going to be watching tonight on the polling returns. The lens is right here, a clear structure that is right behind the pupil. You don't see it normally, and in fact my little 4-year-old said, "Mommy, that's easy, it's a white thing in your black thing," and that is what happens when a cataract develops. So the lens is right here, and the lens serves to focus light on the retina. The retina people liken to the film of the eye. It's the neurosensory part of the eye that sends the information back to the brain. So the lens focuses light on the retina. It also helps filter out harmful UV rays, and physiologically with time it loses its flexibility and clarity with age. So this is actually how a cataract forms. A cataract is a clouding of the eye's natural lens. Here you can see the normal lens, and with time it becomes inflexible and opaque and impairs the transmission of light to the retina. So a cataract is a physiologic change, much like the hair turning gray. We always liken the eye to a camera. An image is viewed, the light is focused by the lens, and a clear image is produced on the retina. A cataract is similar to having a dirty lens, grease on the lens or fingerprints, and gives you an obscured, dirty, greasy view on the retina. And it scatters light. It might give you, this is something a cataract patient may see. You see a building and you have this very blurry, obscured area centrally, and the view is not normal. The lens consists of an inner nuclear layer, and here's a nuclear cataract, an outer cortical segment, and a surrounding capsule. And a cataract may form in any of these areas or all three, and we're finding that it's important to distinguish from a research standpoint in which area the cataract develops. Cataracts can cause symptoms such as halos and glare. It can also cause a dulling or brownish appearance in color and what the person is looking at. So it's quality of vision that is impaired too. And in some of the famous painters' works, Rembrandt, etc., you may notice a change in their colors that they used in their painting, and the way that their painting changed as their cataract developed, and then subsequently after their cataract surgery, which at that point in time was very crude. So various types of cataracts form, and we just want to dispel some myths. A cataract is not a film over the eye. It's not a growth. It's not caused by eye strain, and it's not spread from one eye to the other. Now look at this. I think this is very impressive. So here's a white thing in your black thing, a cataract. It is the single greatest cause of blindness worldwide. Causes half of all blindness. 17 million people in the world are blind from cataract. Estimates show that 40 million will be blind from cataract by the year 2025. It is the third leading preventable cause of blindness in the United States. And cataract, as I mentioned, the development is age-related. 10% of all Americans, but when you break it down by age group, you can see 50% of people between 65 and 74, 70% of people over 75. If you sat every person 60 down at the slit lamp in the eye clinic, 96% would show some evidence of cataract formation. Now, only 15% in this age range will have vision diminish significantly from that, but it is, as I stated, a physiologic change. And the problem of cataract blindness is worsening. As the life expectancy increases worldwide, this is going to become more prevalent, and the population at greatest risk is estimated to quadruple in developing regions between 1980 and 2025. Fortunately, treatment exists, and treatment is curative. Cataract surgery is the single most effective operation performed in medicine today. The problem is that poor countries have their resources outstripped by the demand for cataract surgery. There just aren't enough supplies, physicians to go around, money to go around to take care of these patients. Rich countries, such as ours, have an increasing proportion of our resources consumed by treating cataract. What has happened is that we have had unprecedented technological developments in our surgery and with lens implantation that has really revolutionized the visual expectations and the lifestyles of the elderly. They have decided that dull vision is dull and that they want more out of life and are entitled to more, and this is what we want them to realize. But ultimately, this has led to a dramatic increase in the number of procedures performed. Let me just tell you a little bit about that. U.S. cataract surgery. Compared to the decade before 1976, cataract surgery each year has increased 177%. Over 1 million cases have been performed in each year after 1987. 1,200,000 intraocular lenses were implanted in 1988. This is 97% of all cases had lens implants performed, and there was a total of about 1.25 million cases done. 12% of the entire U.S. Medicare budget is spent on cataract surgery. And you can't see this number well down here, but it's $9.9 billion annually. So a very significant problem. But as you can imagine, cataract causes severe individual limitations, staggering economic burden, and that makes us realize this. And I want to spend a fair amount of time talking about this today. It should be an urgent priority of us to understand the biochemistry and physiology of cataract so that prevention and non-surgical medical therapies can be developed. So we need to understand why cataract occurs. It's a multifactorial process, and we feel that it's a cumulative occurrence. Many insults add up to produce a loss of transparency of the lens. We know that it occurs with aging, diabetes, family history, after trauma, and secondary to certain medications. Studies have shown that risk factors for cataract are age, female sex, geographic location, particularly near the sun and UV radiation, ionizing radiation, nutrition, diabetes, drugs, alcohol, smoking, trauma, etc. It's been associated with low socioeconomic indicators. Some protective factors that we've been finding out are multivitamin supplements, dietary intake of riboflavin, vitamin C, E, and carotene, the antioxidants, and niacin, thiamine, and iron. So what about prevention and non-surgical treatment? Unfortunately, there are no proven measures, and research is abundant, fortunately, and it is imperative that we continue this research. There are basically 3 types of research that is going on: in vitro experiments, animal models, and epidemiological human studies. As far back as 1928, some animal studies suggested an association between nutrition and cataract. And they associated cataract in animals with a low protein diet, low specific amino acids, and high lactose. And subsequently in some human studies, they noticed protein deficiency, tryptophan metabolism, riboflavin, vitamin C, selenium, and lactose metabolism had to do with cataract formation. So recently, this research has focused on the relationship between antioxidant status and cataract risk. Let's talk a little bit about antioxidants. Y'all probably heard some about this. Free radical mediated pathology. Free radicals are substances that are produced and seem to be implicated in cataract formation. Because we are air-breathing, oxygen-using organisms, metabolic processes occur in our body that produce byproducts, free radical products, and these can cause structural and functional cell damage. Antioxidants are substances and molecules that protect or repair the tissue when this free radical damage occurs. Antioxidants are now the subject of extensive research. Nutritional status may influence cataract formation in humans. Cataract formation may be delayed by lens antioxidants and accelerated by oxidants, and this is from an American Journal of Clinical Nutrition in '88. Subjects, they looked at high levels of vitamins E, C, and carotenoids, and these are antioxidant vitamins. Subjects who had high levels of at least 2 of 3 of these were at decreased risk of cataract compared to subjects with low levels. So further study goes on, and another article out of the Journal of Clinical Nutrition showed that oxidation of lens proteins may play an important role in the cataract risk, and they noticed that patients who had low vitamin C intake had an increased risk of cortical and capsular cataract. Patients that consumed low quantities of fruits and vegetables per day had an increased risk of cortical and capsular cataract. They noticed that there was a decreased risk of cataract by 50% in patients who had increased supplementation of these antioxidant vitamins, and that patients who had decreased serum levels of these had more cataracts. Randomized controlled vitamin supplement studies are warranted. So animal research also suggests the role of micronutrients with antioxidant capabilities. This is a very significant article or editorial out of the Archives of Ophthalmology in 10 of 90, and it does say, yes, our research supports this, but that we need to beware of widespread use of vitamin supplements in the absence of controlled studies and proven effectiveness. This is such a grave problem, and it would be so wonderful if something as benign and innocuous as vitamins would help, that everybody wants to jump on the bandwagon. But really, we need to wait until studies are out that prove this. And right now at the National Eye Institute, a multi-year study is underway looking at the clinical course and progression of macular degeneration and cataract, and there's a specific arm in the trial to look at vitamin and mineral supplementation. Now this is about a 10-year study, and it may even take 20 years to find out the results, but hopefully within our lifetime we will know the answer to this. The risk of nuclear cataract increases with smoking, and I thought this was a very interesting article from the Archives of Ophthalmology in '89. The risk increases with the amount smoked, excuse me, and decreases if the subject quits.
Just talking about smoking will do it. Anyway, further investigation is warranted. I think so. My throat is just giving out. Okay. And I'm not a smoker. So I think that's interesting. And one thing I do tell my patients is that possibly they should stop their smoking if for this reason. I know they're given many reasons, but certainly for this reason. Another thing that has been correlated with cataract is exposure to UV light. And particularly in the UVB range, 295 to 320 nanometers, they've associated cortical and capsular cataracts, not nuclear again, whereas smoking was nuclear. And something that is very benign to do is wear a hat and use sunglasses. And we found that a brimmed hat can cut exposure by 50%. So basically, in vitro studies showed that the lens was susceptible to damage by oxygen. High vitamin C levels in the aqueous had a protective function against the stress on the lens. Vitamin E was similar, and possibly we should develop topical drops of vitamin C and E. For the past 100 years, we've had animal studies and we've had animal models of cataract formation, and this has really been one of the most important trends in lens research. And basically, you can see some important discoveries here. 1989, they saw that caloric restriction delayed cataract formation in the emery mouse. And in 1991, vitamin C prevented cataract induced by selenite. So just to really tell you a last few things about some of the research, the most studied cataracts are those caused by sugar. How are cataracts treated? Again, no medical treatment. These super pinhole glasses you see on TV don't work. Eating lots of carrots won't work, and there's no magic bullet. Early on, frequent refraction and changing your glasses may help, and this may need to be done every 6 to 12 months for somebody. But cataract surgery is the only way to successfully remove the cataract. It is the most frequently performed surgical procedure in the United States, and it is state-of-the-art. It safely, quickly, and effectively improves vision. When should surgery be considered? It is really up to each individual to decide when to have the cataracts removed. It is a very, very personal decision. And I think that, we can have indications such as if your vision is less than 20/40, if there's a certain amount of glare and contrast sensitivity. But I think the most important thing is, what is each patient's specific need? Does the patient need to drive? If they're having trouble from glare and halos and they can't drive. If they're diabetic and they need to see the numbers on their insulin syringe. The main question I ask this to every patient, and you all can ask this question too, is your vision interfering with your lifestyle and keeping you from participating in your usual activities? And if it is, it's time to have the cataract taken out. And many elderly patients get their greatest satisfaction out of reading. And if they cannot read, then no matter how old they are, it's important for them to have that vision restored and have their cataract operation. Now, I've included these historical photos. We've come a long way in cataract surgery. I don't bring my dog with me to the operating room anymore, and we try to use a little different setup than this. I don't wear a wig either. But this is couching a cataract. This is early 17th century, and really not a lot had changed since ancient Egyptian times. And basically, they stuck a needle in the eye and tried to dislocate the lens into the back of the eye. Well, back here, you truly wanted to wait until the cataract is ripe. We no longer have to do that. Surgery is so effective now that in more than 90% of cases, there is a great restoration of vision, 20/40 or better vision, and it is usually performed using local anesthesia. Remember, cataracts are not removed with a laser. This is a big myth that we need to dispel, and my patients always ask me about that. You're not going to do that laser surgery? Well, let's talk a little bit about the different types of cataract surgery. There's 3 basic types: intracapsular cataract extraction, extracapsular cataract extraction, and phaco emulsification, which is really a type of extracapsular surgery. Intracapsular is when the lens is removed within its capsule. There's a very large incision made. Extracapsular is a smaller incision, and we open up the capsule, take out the nucleus and cortical material, and leave that little bag in which we put the lens implant. And finally, the most recent thing that we're doing, and this is what you're hearing a lot about, is phaco emulsification. And we perform the whole operation through a 3mm incision, which is very, very small. We use a probe which has ultrasound power in it, which fragments the lens, and we're able to aspirate it through the small incision, leaving the capsule, and we're able to put the implant in. And this allows the patient a rapid return to normal activity, less astigmatism, which it means they won't need much spectacle correction. The problem is that a little more skill is required, and it's a more expensive procedure. So here's intracapsular. Here they are making this big wound with these great big scissors, and the wound extends about halfway around the cornea. And they stick in a big ice probe, and you take out the entire lens. So here it is with the probe on the lens. See how much of this eye is opened up? And then pulling out that whole lens with that probe. Then we realized it was important to leave that capsule in, because then we had a place that we could put the lens implant that was physiologic. So in extracapsular techniques, you make a smaller incision, about 11 millimeters,
and you deliver this nucleus in one piece and then sew it up. And now phaco emulsification instrumentation has come along, and here our incision is just 3 millimeters. It's the width of this instrument, and we use this to suction and fragment and break up the cataract. And as you can imagine, the way that we construct this wound, it can be closed with no sutures or just a couple. Now, when you take the lens out of the eye, nothing is left to focus the light on the retina. So you're left with a situation called aphakia. So here, normally you have the lens. When you have the intracapsular form, you have to either use these cataract glasses, and as you can imagine, these are thick. You only see out of the middle of them. They're heavy, they're cumbersome. When the patient doesn't have their glasses on, they can't see. They're legally blind. So that's one option. These cause magnification of the image by 33%. So when they're looking at something, the image is 33% bigger than what it really is. A contact lens is the next option. It only magnifies 13%, which is a little better. But the problem is it's often difficult for the elderly to put a contact lens in and out every day, particularly if they have Parkinson's or other problems. So the big revolution is the lens implant. And here's a contact lens. And here are two types of lens implants. This is an anterior chamber lens, which you see in front of the iris, and that can be put in intracapsular or extracapsular. And this is the posterior chamber lens, which is behind the iris in the normal physiologic place that the lens usually occurs. So here's where the cataract was. We leave the little bag and put the implant in. And here's just showing you the size relationship and some various designs of these lenses, which are made out of polymethyl methacrylate, a plastic. Some of these loops are Prolene. These are called haptics, and they position and hold the lens steady in the eye. It can also be made out of silicone and some other materials. Now look at this, changing indications. We looked between 1974 and it's actually 1988. In 74, 90% of the cases were intracapsular, and we waited until the patients were legally blind to operate. By 88, 90% were extracapsular, 90% had lens implants, and we're now operating when the patients are 20/60 and now even 20/40. The lens implant really affords better post-op visual rehabilitation. The public now views cataract surgery as safer. And I really feel like the lens implant has revolutionized what we can do with patients after cataract surgery. Our goal is now for patients to not have to wear glasses after surgery, for patients to have perfect vision after surgery. There's several types of lenses. We want the lens to be as close as possible to the normal human lens. Now the normal human lens when you're young focuses and changes focus. When you hit about 40 or 45, it stops focusing, and that's why everybody ends up wearing reading glasses or bifocals. When we put the lens implant in, it doesn't vary the focus. But what we're trying to do is go from a monofocal lens that puts you either at distance or near to a bifocal or multifocal lens that may let you see at distance and at near and not need your glasses anymore. There's also foldable lenses which can be placed through a very small incision. So this is a picture from the back of the eye, Miyake view of one of these posterior chamber lenses in the eye. And here is a picture of one of the posterior chamber lenses being inserted in this hole in the capsule through a very small incision up here with some forceps and tucked under the capsule behind the iris. Now closing the wound, you hear a lot about sutureless surgery and this or that. My feeling is that if the wound is constructed right, it doesn't need sutures, but sutures are not bad, sutures are good. I wouldn't think of having any other operation without sutures. I think they make the wound strong, and I think whatever procedure your ophthalmologist is used to and does the best is the best one to have done. With an extracapsular procedure, you have several sutures placed to close this wound. With the phaco, and after putting in a lens, you may have just a couple little stitches or one stitch up here closing that wound. And we talk about these self-sealing incisions. We try to make these beveled incisions, and so that when you finish, you really don't need a stitch in the eye. And this is particularly useful if you're using one of these silicone foldable lenses. We fold it up in a little forcep and introduce it into the eye, and then it unfolds. And so it can fit through a very, very small hole.
What are potential problems with cataract surgery? Bleeding, infection, macular edema or swelling in the retina, retinal detachment, swelling of the cornea, and glaucoma. But fortunately, these complications happen less than 1% of the time. For example, infection less than 0.5% of the time. It's a very safe procedure. And this study from British Journal of Ophthalmology looked comparing recent improvements in technique, lens design, and materials to the old techniques and said, yes, there has been a steady decline in complications, less post-operative glaucoma. Now what we are seeing is some posterior capsular thickening. We're leaving that capsule in, and 13 to 50% of the time it is becoming thick and opacified, and this is where you'll hear about laser surgery. Decreased vitreous loss, or rupturing that capsule and having the jelly from the back of the eye come to the front of the eye, and decreased reduced vision at 3 months. The major complications, macular edema, retinal detachment, and infection occur in less than 1% of cases, and most complications can be treated. Now, one thing that our federal government did to us was they all of a sudden said, if your patient has Medicare, you may no longer admit them to the hospital after their cataract surgery. So patients started having outpatient surgery. And then a couple years later, we went back and looked at this retrospectively and said, thank goodness they did okay. My hope is that in the future, we are able to do the studies ahead of time and then let the government tell us what to do with our patients. I think we got very lucky here. But they compared 300 inpatients to 300 outpatients and found there was no difference in the visual outcome or complication rates, including wound dehiscence, filtering blebs, infection, detachment, and those sorts of things. This is what I was talking about, the laser surgery. Okay, the lens is here in this capsule, and this is the little membrane that about a year or so after surgery can become thickened. We used to have to take the patient back to surgery and with a knife make an opening in this. Here they are at the slit lamp, and what we do now is they sit at a laser beam, and the laser beam cuts a little hole in the center of this, and it's clear, and it's painless, and it takes about 5 to 10 minutes. So this is when you hear about laser surgery for the second or after cataract, and it is wonderful. So when this happens and drops their vision down, we open it up. Rehabilitation. I really think that the rehabilitation is a very important issue. People don't want to miss work. They don't want to not be able to take care of their grandchildren. It's a very important aspect of quality of care. Many years ago, we put patients in dark rooms with sandbags on their eyes and they couldn't move for days. 5 to 10 years ago, or not even that many years ago, they had 5 to 10 days in the hospital, minimal movement, heavy unattractive glasses afterwards. Now we give our patients a shield or some glasses and say wear them for 3 to 6 weeks, don't do any lifting or bending, try to remain sedentary and don't really do any hair washing or showering, and that's not too bad. Now, Dr. Olson out of Utah looked at 216 of his patients after phaco, and all he told them was, do whatever you want, but stop when it hurts. And they had no shield, no instructions regarding anything else, and there were no complications related to activity. So really, this just suggests that maybe we reevaluate our restrictions and do some more studies on this. The patient has to use drops a few days post-op, but really they're back to their normal activities very, very quickly. And with our new techniques, they're seeing well, especially if they have phacoemulsification, they are seeing well the week or so after surgery. Very, very well. But no matter what technique is used, if the patient's macula or retina is normal, 85 to 95% achieve 20/40 or better vision in 3 months, and it only takes 20/50 to read the newspaper. There's better color vision, less distortion, and better reading, and I think we really consider this one of the everyday miracles of medicine. So I just want to remind you, if you ever have any questions about cataract, an excellent resource is the American Academy of Ophthalmology, and they can refer you to ophthalmologists. They can give you information and be very, very helpful. So a grave public health problem, and something that you all can do a lot about by educating your patients. And as you can see, it's come a long way. The treatment is efficacious, but what we would like to find is A, prevention, and B,
non-surgical treatment so that it can be provided to everyone. This is truly a worldwide problem. And now I'd like to open it up for discussion. One of the things I'd like to mention is there is somewhat of a discrepancy. A Baltimore study looked at patients and said, you know, there's still a large percentage of our population that is blind from cataract. We're not reaching the poor population. We're not reaching the black population. We are not reaching everybody in our own country. And this is truly a worldwide problem, but it's even a problem here in our country. And there's lots of things that we can do by educating people, telling them to have eye exams. A lot of the elderly think it's normal for their vision to go down. And so they get used to having poor vision and they don't go in. And we're really finding if they're educated and go in and have high expectations, they will do well. And do it before they get used to having poor vision. And so I'll take any questions now. I have a few interesting studies here. Ruth mentioned some of the things that you all might be interested in. One of them was functional outcome, 1 year after surgery, looking at cataract surgery in elderly patients. And a lot of the things that we're looking at now are quality of life issues. We know that they all will have better vision, but does this make a difference? And they've really found that it depends on how active were they before their surgery, what was their mental status before their surgery, and if their mental status and activities were good, they're going to be excellent after their surgery. And it was really correlated with that. So there's a lot of study that needs to be going with this, and a lot of study that's going on as far as quality of life issues with cataract surgery.
So are you saying it's economically driven, whether they have cataract surgery or not?
Whether they don't, whether they are not, yeah.